Hello, welcome you all in Mystifying Medicine. Today we start with Passmedicine lecture series for Mrcp part 1, which are also helpful for other exams. So we start with respiratory section. First topic will be the asthma. So we will go through whole of this topic. So what are the features of acute asthma? Acute asthma is nearly always seen in patients who have got a history of asthma, like features worsening dyspnea, wheezes, cough that is not responding to salbutamol, may be triggered by the respiratory tract infection. As patient has a history of asthma, either allergen, pollutants, or any atopy or eczema. If they come with worsening of dyspnea, wheezes, or cough, or if they not respond to the salbutamol, or may have a superimposed infection like respiratory tract infection, so it is an exacerbation of this. So in acute severe asthma, this is stratified into the four main types, like moderate, severe or life-threatening asthma, and near lethal asthma. In moderate asthma, the peak expiratory flow rate will be 50 to 75% best or predicted. Speech will be normal. Respiratory rate will be 25%. Respiratory rate will be 25 breaths per minute, and pulse will be less than 110 beats per minute. In severe asthma, peak expiratory flow rate will be 33 to 50% of the best or for the predicted, and patient unable to complete the whole of the sentences. Respiratory rate will be more than 25 breaths per minute, and the pulse more than 110 beats per minute. So there's a difference between moderate and severe is peak expiratory flow rate, that is a 50 to 75%, and in the severe asthma 30 to 50%. And in this, speech is normal. In the moderate asthma, in severe, patient unable to complete the sentences. Respiratory rate will be less than 25%, less than 25 breaths per minute, and in severe asthma more than 25 breaths per minute. In the pulse, less than 110 beats per minute, and in severe more than 110 beats per minute. So here you can compare the life-threatening and the near lethal asthma. In this, peak expiratory flow rate will be less than 33 best predicted, and oxygen saturation will be less than 92. On auscultation, chest will be silent, patient will be cyanosed, feeble pulses, decreased respiratory efforts, bradycardia, dysarrhythmias, or hypotension, and patient will exhaust and may confusion or the coma. In this life-threatening or moderate or the severe asthma, there will be the normal PCO2 that indicates the exhaustion and should therefore be classified as a life-threatening. In moderate and severe, when there the respiratory rate will be the high, so patient wash out the carbon dioxide. So carbon dioxide will be low in moderate and severe, and life-threatening asthma, the carbon dioxide will be normal. So in acute setting, here you can see a fourth category is a near lethal asthma. It is characterized by the raised PCO2. In life-threatening and near fatal asthma, both symptoms are mostly the same, but main difference is the PCO2 that is increased in the near fatal asthma as compared to life-threatening asthma. So in near fatal asthma, that requires mechanical ventilation with raised inflation pressure. Always remember this. Life-threatening asthma also need the mechanical ventilation. So for the further assessment, according to the BTS guideline, recommended the ABGs. So ABGs are important to monitor the pH and PCO2 level to decide about the mechanical ventilation and the pressures. And if cause is unknown, or if patient then chest x-ray is routinely recommended. In the life-threatening asthma, suspected pneumothorax or patient failure to respond to the acute treatment. So how will you manage this patient? All the patient with the life-threatening should be admitted in hospital. Patient with features of severe acute asthma should be admitted if they fail to respond to the initial treatment. Or other admission criteria include the previous nasal near fatal asthma, or pregnancy, or an acute occurring despite already using oral corticosteroid and presentation at night. So who should be admitted? The patient who has a life-threatening should be admitted in hospital, and the patient with severe acute asthma or previous history of near fatal asthma, pregnancy, and acute an attack occurring despite already using oral corticosteroid and presentation at night. So start with the oxygen. If patient is hypoxemic, start the oxygen. Start them with the supplemental oxygen. You can use, if patient is acutely unwell, not maintaining saturation, then start it to the high flow oxygen 15 liter through the non-rebreather mask. And you have to maintain the saturation of 94 to 98. And then use the bronchodilator. Always first step as a BTS guideline, start with a short acting beta agonist. High dose inhaled SABA like salbutamol or terbutaline should be given. In patient without features of life-threatening or near fetal asthma, this can be given on the standard pressurized meter dose or oxygen-driven nebulizers. In patient with the features of life-threatening exacerbation asthma, nebulized SABA is recommended. Other step is the corticosteroid. All patients should be given 40 to 50 mg of prednisolone orally daily, which should be continued at least 5 days or until the patient recovers from the attack. During this time, patient should continue their normal medication routine, including inhaled corticosteroid, apratropium bromide, as it is a beta 2 agonist, and corticosteroid, nebulized apratropium, and short acting muscarinic antagonist. IV magnesium sulfate is given in the severe cases, as now it is recommended in severe or the life-threatening asthma. Before giving the magnesium sulfate, you must check the blood pressures of that patient, because it causes the hypotension, and you should monitor the reflexes urinary output when you start the patient on magnesium sulfate. IV aminophylidine is mostly not recommended in the asthmatic patient. It is mostly recommended in the patient of COPD. Patient who fail to respond to these all 3 to 4 acute management, then patient should be referred to the critical care unit and admitted to the intensive care unit or the STU setting, where if patient is still unable to maintain oxygenation, still symptomatic, or patient has a life-threatening or the severe asthma, patient should be intubated and ventilation is required, either extracorporeal membrane oxygenation, ECMO. If patient, so when to discharge this patient? Being stable patient, discharge on the medication, and there is no any use of oxygen or the nebulizer for 12 to 24 hours. And inhaler technique should be checked and recorded as they go home. They may not use as a proper way, so they come back to you again with the exacerbations. Peak expiratory flow rate more than 75% of best predicted should be discharged. And here is another topic: how to diagnose the asthma. NICE released guidance on the management of asthma in 2017. This is followed quickly by the BTS guidelines. So NICE radically changed how asthma should be diagnosed. It advocates moving anyway, either subjective, clinical judgment, or more towards the objective test. As patient has already history of allergy and came with the history of dyspnea or like symptoms like cough and wheezes, so you can clinically judge the patient that he has a asthma. And other tests are subjective, some are subjective and some are objective. Here is a test that is known as a fractional exhaled nitric oxide. What is the concept of this? This nitric oxide is released particularly from the eosinophils. As patient has an allergic asthma and it releases a lot of eosinophils, so that from that eosinophils nitric oxide released, and that could be measured, and that levels of nitric oxide typically correlate with the level of inflammation. Other more established objective tests such as the spirometry or peak flow variability test are still important. If child is more than 5 years, you should have the objective test like suspected asthma reached at the age of 5 years. Objective test should be performed to confirm the diagnosis. As it is difficult in the children to perform the test, that's why more than 5 years the objective test should be performed. Otherwise diagnose the children on the basis of clinical judgment. And diagnostic testing: if patient is more than 17 years, patient should be asked if their symptoms are better on the days away from the work or during holidays to rule out the occupational asthma. All the patients should have spirometry and the bronchodilator reversibility test. All patients should have FeNO, fractional inhaled exhaled nitric oxide test. If children is 5 to 16 years of age, all children should have the spirometry and bronchodilator reversibility test, and FeNO test should be requested if this is normal. If there is a normal spirometry or obstructive spirometry with the negative bronchodilator reversibility test, then FeNO is required to test in children 5 to 16 years of age. Patient if less than 5 years of age should be on clinical judgment. So in 17 years you go for the spirometry and bronchodilator with bronchodilator reversibility test and FeNO test. In 5 to 16 years of age you should go for the spirometry and bronchodilator reversibility test, but FeNO should be requested if spirometry result will be the normal or the obstructive, or both of the like spirometry or the bronchodilator reversibility become negative, then advise the children about 5 to 16 years for FeNO test for confirm their diagnosis. So there are some specific points about the test that in adults more than 40 parts per billion is considered positive, and in children more than 35 parts per billion is considered positive. Spirometry FEV1 less than 70% or below the normal limit, if the value is available, is considered obstructive, because 80% of FEV1 ratio is normal. If less than this, shows the obstructive pattern. If more than or equal to 80%, shows the restrictive pattern. So it is less than 70 is less than 80, then it is a obstructive pattern, so it is likely to be the asthma. For the reversibility test, this is also occur in the COPDs, that spirometry may give the obstructive pattern, but how to differentiate between COPD and asthma, we go for the reversibility test. If patient improve with bronchodilator, improvement occur in the FEV1, that's the most likely asthma. But in COPD, there is a no improvement occur after the reversibility test. So by this we can differentiate between the asthma and the COPD. In adults, positive test is indicated an improvement in FEV1 12% or more, increase in volume of 200 ml or more. In children, a positive test is indicated an improvement 12% or the more. So in the management in the adults, NICE released guidance on the management of asthma in 2017. These followed on quickly on 2016 BTS guideline. So in this, here is a whole of the table I want to discuss it. If patient is a newly diagnosed asthma or patient is asymptomatic, always start with the SABA, short acting beta agonist, that is the salbutamol. After giving the SABA, check for the response. If asthma is not controlled, move to the step 2. Or newly diagnosed asthma, patient has a more than 3 weeks of nighttime waking, means still patient is asymptomatic, then add the SABA with the inhaled corticosteroids. Start with the low dose. If patient is still in step 3, is still patient is symptomatic, then add the leukotriene receptor antagonist. And in the 4, if patient has a short acting beta agonist and the low dose ICS used, if patient is still symptomatic, add the LABA. Remember, LABA is only effective when it is given with the inhaled corticosteroids. And continue leukotriene receptor antagonist depend on the patient response to the leukotriene receptor antagonist. If you add SABA and ICS, add on the LABA, and leukotriene receptor antagonist will be the plus minus. If it give the response, then add. If it doesn't response, then switch LABA with the ICS. And in the step 5 and the 6, we go for the maintenance therapy. Maintenance therapy, we have 2 options, like inhaled corticosteroid with the SABA as a maintenance and the reliever therapy. In this, we add the low dose inhaled corticosteroid with the long acting beta agonist. And in the 6th, either change to the back to the fixed dose, moderate dose ICS, and or separate the LABA. In the step 7, either add SABA with leukotriene receptor antagonist or increase to the high dose of inhaled corticosteroid as a fixed regime, not as a MAD. Or you can add on the other like LAMA, like a long acting muscarinic agent or the theophylline. If still it is not controlled, so you should revise the diagnosis or seek the health care professional expertise in asthma. So in the nutshell, start with the SABA, not controlled asthma, add on the inhaled corticosteroid. Still not responding, add leukotriene receptor antagonist or LABA. If it is controlled on the LABA, continue LABA. If it is not controlled on LABA, then stop the LABA and then increase the dose of inhaled corticosteroids. And step 4 and 5, low dose, we use the maintenance therapy or the reliever therapy reliever therapy for low dose inhaled corticosteroids and LABA. And the step 7, SABA or leukotriene receptor antagonist with increase to the inhaled. In this we add as a medium, low to medium dose. In step 5 and 6, inhaled corticosteroids, and in step 7 we use the high dose inhaled corticosteroids. So maintenance and the reliever therapy is said as a MART therapy, a form of ICS and the LABA treatment in which single inhaler is used. Both ICS or fast acting LABA, both should be used daily. MART is only available in ICS or the LABA combination. Like example is a formoterol for the LABA. It should be noted that NICE do not advocate changing treatment in patient who has a well controlled asthma. If patient has a adequate controlled on the asthma as a stepwise approach, stop there and continue as a maintenance therapy. There is no need to change any of the treatment. So simply adhere to the latest guidelines. If less than 400 less than 400 microgram is said as the low dose, 400 to 800 said as a moderate inhaled corticosteroid, more than 800 known as a high dose. And last one is a occupational asthma. Occupational asthma is patient may either present with the concern that chemical at work or worsening their asthma, as you may notice in the history that symptoms seem better than the weekends when away from the work. Exposure of the following chemicals is associated with the occupational asthma. The most common is the isocyanates. Isocyanates is the most common cause of the occupational asthma. Spray painting, foam molding or adhesives. These are the isocyanates. Platinum is salts, soldering, flux resins, glutaraldehyde, fluor, epoxy resins or proteolytic enzymes. If any of the exposure occur, then patient may have the occupational asthma. So the RCP mostly tests the most common causes. So isocyanates, you should remember this, because RCP may give in a statement like patient or the person who has been working for the years in the spray painting now came with the shortness of breath or wheezing. Now what is the most probably the cause of this? Then you may say that is the isocyanates, occupational asthma. Or maybe they test your knowledge by a cause, or maybe test by the diagnosis. So what to do? We will diagnose with serial measurement of peak expiratory flow recommended at work or away from the work. If patient is working and he came to you with the symptoms, serial measurement, you note the peak flow expiratory flow rate when he is on the work, and otherwise is recommended when he is on the holiday. And the most probably the best treatment for the occupational asthma is to avoid the exposure. So referral should be made respiratory specialist for the patient with suspected occupational asthma. So here we done with all of the asthma from the Passmedicine notes. For the more updates, like my video and subscribe my channel for more updates. For further we can discuss about the more RCP questions. So thank you so much.